Welcome, everyone. Hello. Thank you for coming to the modeling and simulation session. I hope everyone is having a wonderful conference so far. I'm Ann Silverman. I'm an associate professor of mechanical engineering at the Colorado School of Mines. I'm honored to be co-moderating this session today with Brecca Graffney, who's an assistant professor of mechanical engineering at the University of Colorado at Denver, and Russell Johnson, who is a postdoctoral research associate at the University of Southern California. We have a great lineup of speakers for the next hour and a half. We'll have 3 blocks of talks in this session, with each block having 4 back-to-back 5-minute talks, followed by 10 minutes of questions. For the question period, we ask that you either raise your hand to ask questions during the question period, and one of the moderators will call on you, or you can put your questions in the chat throughout the session. And when you do that, please indicate which speaker the question is directed at. One of the moderators will ask the question of the speaker during the question period. We are on a quick timeline, and so it's highly likely we will not get to every question. And so there's a reminder that immediately following this session, we will be meeting for an extended discussion and additional questions in the MyBridge spatial chat room. There will be a link in the chat to join that spatial chat room when the time comes. So, as we are on a tight timeline, we will jump right into it. Our first speaker of this session is Julia Noginova. Her talk is entitled Consideration of Subtalar Joint Axis Location in a Dynamic Musculoskeletal Model. Julia, take it away.
Thank you. Can everyone see my screen? All right. So I would first like to start off by thanking my co-authors for all of their work and valuable guidance with this study. When it comes to analysis using musculoskeletal models, the foot is often simplified, which results in the complex nature of the joints being overlooked. For instance, the subtalar joint is usually left locked or described as a 1 degree of freedom joint using a generic axis definition. Since the subtalar joint is primary for load acceptance and transmission to the rest of the kinetic chain, a more subject-specific consideration may be critical. The most commonly used subtalar joint definition follows that as established by Delp, which states that the subtalar joint origin location and axis orientation are both modeled after descriptions by Inman. When Inman collected data on 46 non-weight-bearing cadaver feet, he found the mean and range of subtalar joint inclination and deviation angles. We see from the table on the right that the Delp model definition does fall within this range, though on the low end compared to the mean. Furthermore, the Delp model has the subtalar joint origin located at the distal end of the calcaneus. While there are no accepted standards for the subtalar joint yet, the ISB suggests that the calcaneus coordinate system should be coincident with that of the ankle at the bisection of the intermalleolar axis. As we can see, if we move the subtalar joint origin location to be in line with the ankle, the Delp's rotational axis, seen in green, remains exactly the same. However, when a different subtalar joint orientation is used, like Inman's, seen in figure B, the change in origin location affects how the axis of rotation crosses through the talus. In this study, we wanted to determine how this change to both the origin location of the subtalar joint and the axis orientation affect the lower kinetic chain, all the way from the subtalar joint to the knee. Using walking data from the Grand Knee Challenge for 3 subjects, the peak joint moments and joint loads were compared using paired t-tests for all combinations. The RMS and correlation were also compared between estimated knee loads calculated through OPENSIM and the in vivo measurements collected using the instrumented knee implants. So as we can see in the slide, moving the origin location from the calcaneus to the talus leads to no differences in the 1 degree of freedom rotational axis for the Delp orientation. So no significant difference is seen in joint calculations, shown by the black. However, when utilizing Inman's mean orientation, moving the subtalar joint origin location from the heel to the ankle results in significant differences in peak subtalar joint moments, as well as peak contact forces for all the rest of the kinetic chain, from the subtalar joint, the ankle, and even to the knee. By changing the origin location to match the suggestion by the ISB, the difference between the two Inman orientation models is minimized, with knee load correlation increasing from 0.81 to 0.95 when comparing to the load collected with the instrumented knee. In all measures, when using the talus as the axis origin location, the difference between the subtalar joint orientations is minimized. This is seen by the close values between the DELP and Inman orientations when the ankle was used as the origin location. The results of this study show that when considering subject-specific definitions and models, the location of the subtalar joint origin has more of an impact on the results than the orientation alone. Therefore, in the case of healthy feet, a generic axis definition may be enough when analyzing regular gait. However, a more specific axis may still be necessary in deformed feet or when a more dynamic activity that involves subtalar joint motion is analyzed, like a cutting task or walking on uneven ground. Thank you.
Thank you very much, Julia, for that great talk. We are going back to back with talks, so we will now go to our second talk of the session from Kelsey Neal, Change in Knee Cartilage Stresses from 6 to 24 months after ACL reconstruction, a preliminary analysis.
Sorry, I had to find my unmute button. Thank you. All right, so everybody see my screen? Right. ACL injuries are common among young active populations. Many who tear their ACL choose to undergo an ACLR or an ACL reconstruction surgery in hopes of regaining joint stability and returning to pre-injury levels of activity. While joint stability is often recovered, this procedure does not guarantee long-term joint health, with about 30% of individuals who undergo an ACLR showing signs of osteoarthritis within 5 years. And while stability is often regained, ACLR has not been successful at restoring pre-injury gait biomechanics. Using a combination of inverse and forward dynamics, along with EMG-driven musculoskeletal models, we have been able to assess how joint loading changes over time after ACLR, and have found that individuals who develop OA within 5 years tend to underload their medial joint compartment 6 months after ACLR, suggesting an association between biomechanical alterations and the eventual development of osteoarthritis. However, these approaches are unable to provide insight into how the load is distributed within the knee joint and how changes in gait biomechanics may be shifting stress distributions throughout the cartilage. Finite element modeling is a non-invasive way to help shed light on this topic. Specifically, for this study, we sought to assess peak stresses in different regions of the medial tibial cartilage at 6 and 24 months after ACLR. The model developed for this study is based off of a single female subject with a unilateral ACLR. Model development consisted of segmenting proton density MR images to gain subject-specific geometries. Meshes were generated using HyperMesh and an open source software developed by Rodriguez Villa et al. Tissue models were chosen based off of existing literature values, and model constraints were implemented to minimize the geometry needed to help stabilize the model. Motion analysis with EMG was performed at 6 and 24 months after ACLR. Inverse and forward dynamics were used to obtain muscle force estimations, which were then input into a validated EMG-driven musculoskeletal model where joint loads were calculated and used as inputs to the FE model. The model inputs were applied quasi-statically in 2 steps. The tibia was held fixed in all directions, while the loads and moments were applied to the femur at the center of the transepicondylar axis. Step 1 applied the peak flexion angle, and step 2 applied the knee adduction moment and the total joint contact forces at peak knee flexion angle. The model output of interest was peak von Mises stress, for 5 regions of the medial tibial cartilage. To help orient you to the graph, we have our 5 regions of interest on the x-axis and peak von Mises stresses on the y-axis. The involved limb is shown in yellow, and the solid bar represents the 6-month time point. At 6 months, the involved limb experienced lower stresses in 3 out of the 5 regions compared to the uninvolved limb. These lower stresses correspond to the lower medial compartment force in the involved limb compared to the uninvolved limb at this time point. At 24 months, the involved limb experienced higher peak von Mises stresses in all 5 regions compared to the uninvolved limb. This most likely can be explained by the reduction in medial compartment force in the uninvolved limb from 6 to 24 months. The involved limb stresses, like its medial compartment forces, stayed similar at both time points. Interestingly, the notable exception to this occurred in the central medial region where osteophytes typically develop. The work presented here showcased an FE model that incorporates subject-specific biomechanics and geometries and allowed us to assess cartilage stresses between limbs and at different time points. At this time, only 1 subject and 1 compartment were assessed. However, future work will explore larger sample sizes via scaling of the existing model. The model is also in the process of being validated against existing FE and cadaveric studies, and thus far has shown to produce results of a similar magnitude. This model is 1 step towards understanding how stresses change within the knee joint over time after ACLR, which may provide insight into why OA is developing after this procedure. Thank you guys for listening to my talk, and please feel free to contact me with any questions during our question block or via email.
Thank you very much, Kelsey. Our next speaker is Molly Shepard, who will be presenting excessive femoral anteversion increases joint reaction forces in dysplastic hips.
Thank you for that. I'm really excited to share this talk on how femoral version deformities alter hip joint loading in patients with hip dysplasia. So developmental dysplasia of the hip, or DDH, is characterized by a shallow acetabulum and leads to cartilage damage and early onset osteoarthritis. Patients with DDH tend to experience higher medially and superiorly directed joint reaction forces during gait than healthy controls. And even after surgery to reorient the acetabulum, many patients still have functional limitations and most still go on to develop OA. Femoral version deformities are common in patients with DDH, with increased anteversion being shown here in the red, referring to angles greater than 15 degrees, and relative retroversion, shown in blue, referring to angles less than 15 degrees. Increased anteversion is more common in patients with DDH and will be the focus of this talk. Femoral version deformities alter the femoral head orientation in the acetabulum. However, their influence on joint biomechanics during gait remains poorly understood. Therefore, the objective of the study was to determine the influence of these femoral version deformities in patients with DDH on hip joint loading during gait through the use of musculoskeletal modeling and Monte Carlo simulation. We created our musculoskeletal models by importing subject-specific pelvis geometries and hip joint centers from MRI, as well as femurs that are scaled baseline femurs with 15 degrees of version. Custom rotation-only joints were added bilaterally just below the lesser trochanter in order to simulate the deformity. Monte Carlo simulation was used to generate a distribution of 2,000 femoral version angles for each subject between -5 degrees, which is relative retroversion, and 35 degrees, which is increased anteversion. Each model was run through a series of OPENSIM analyses in order to calculate muscle forces and hip joint reaction forces. And we're going to focus on this time point of joint reaction force 2, which is the peak resultant joint reaction force, and is right at the toe off period in the gait cycle. So in these figures here, each line represents a different angle of femoral version, with the darker the red color being more anteversion and the darker the blue being more retroversion. So what we found was that increased anteversion increased the anterior, the superior, and the resultant joint reaction force components. There was a decrease in the medial component, however, it was fairly minor. The increased anterior and superior components are especially of interest as labral damage most commonly occurs in the anterior-superior region in patients with hip dysplasia. This suggests that increased anteversion may be contributing to the damage seen in dysplastic hips. In addition, we know that muscle forces contribute to joint reaction forces. So here on the x-axis, we have this change in muscle force with a change in version. So we're going to focus on the more saturated colors, which represents a 15-degree increase in anteversion. So we found that increased anteversion increased the abductor and flexor muscle forces, but caused a decrease in the extensor muscle forces. This may be due to the fact that increased anteversion causes the femoral head to become externally rotated in the hip joint. The external rotation causes those abductor muscles to move from a more lateral position to a more posterior position, which may be contributing to the decrease in the medial joint reaction force components, as well as the increase in those anterior components. They may also contribute to the fact that the extensors are lowered, as that more posterior position of the abductors may take on some of the role of the extensor muscles. The increase in the flexor muscle forces could contribute to those increases seen in the superior joint reaction force components. And while we know that relative retroversion has the opposite effect of increased anteversion, more work is needed to really understand what this means for patients with hip dysplasia. So in conclusion, we found that excessive femoral anteversion increased the muscle-induced hip joint reaction forces. The change in rotation of the femur altered the muscle force and directions, which in turn altered the joint reaction force components' magnitudes and directions. So ultimately what this means is that increased anteversion can help explain mechanisms of damage in dysplastic hips. So with that, I would like to acknowledge our funding sources as well as the Open Science Grid and all my co-authors. Thank you.
Thank you, Molly. Our last talk of the first block of this session is from Alex Denton, Musculoskeletal Simulation Performance in OPENSIM MOCO using parallel computing.
Thank you for the intro. I'm excited to be here. Musculoskeletal modeling and computer simulation is a valuable research approach, but it's always been computationally demanding. Some advancements have reduced computational cost, such as direct collocation, which is computationally very efficient. And recently, OPENSIM MOCO has streamlined the use of direct collocation to further reduce the computational cost. Additionally, parallel computing can further reduce the computational cost. Some parts of a problem may be solved in parallel, such as evaluating columns of the Jacobian constraints matrix. Parallelization has been used in the field for decades, but in the context of massive supercomputers. Now, a multi-core computer with substantially more cores than your everyday computer can easily sit beside your desk. The purpose of this research was to, 1, investigate the computational performance of optimal control simulations of human walking with OPENSIM MOCO using different numbers of processor cores in the parallelization, and 2, to evaluate the interaction between temporal mesh density and the use of a mesh refinement process. And a temporal mesh density discretizes the time interval from T0 to T final. Mesh refinement is commonly used where a solution is first obtained on a coarse mesh, with that solution then being used as the initial guess on a finer mesh, which can lead to better performance starting on a fine mesh. We simulated 2D walking at 1.3 meters per second using the most recent version of OPENSIM MOCO. We ran both tracking and predicted simulations. Simulations were parallelized on a multi-core workstation that recruited a range of processor cores between 1 and 18. A consistent initial guess was used with every mesh interval during parallelization. Additionally, a mesh refinement strategy was used where the solution obtained on a 5 interval mesh was then used as the initial guess for the problem using a 25 interval, and so on. Our primary outcomes were runtime and speed up factor. Here the tracking and parallel simulations are displayed in the columns, and the initial guess strategy corresponds to the rows. All axes display intervals and y-axes display runtime. Here, a lower runtime is better. Greater parallelization, increased simulation runtime, and the mesh refinement strategy also decreased runtime. This is true for both tracking and predictive simulations. Yet the predictive simulations experienced a greater decrease in runtime from both, with the longest simulation taking about 60,000 seconds or 17 hours, and the shortest taking only about 500, which is less than 10 minutes. You can most clearly see this reduced runtime with more cores here, whereas the results are similar throughout, but more compressed for the other conditions. Another way to look at the results is to examine the speedup. Here we have the same layout with the simulation type corresponding to the rows and the initial guess strategy corresponding to the simulation type corresponding to the columns and the initial guess strategy corresponding to the rows. All x-axes display cores and y-axes display speedup. Here, a greater speedup is better. Speedup was calculated as the runtime of the simulation on one core divided by the runtime of the simulation on n cores. With a larger number of mesh intervals, there was a greater speedup, and overall there was a greater speedup for the predictive and tracking simulations. Looking at the 50 and 100 interval meshes in blue and gray respectively, the maximum speedup for the tracking simulations was 2 times faster, whereas the maximum speedup for the predictive simulations was 5 times faster. Both types of simulations, most of the speedup was achieved by about 9 cores, with little meaningful speedup beyond this point. Results indicate multi-core parallel speedup is possible with a 2 to 5 times speedup observed for the current simulations. Although multi-core parallel processing can lead to a potential speedup, this unfortunately seems to be problem specific. The impaired speedup for the tracking simulations relative to the predictive case is likely due to the communication overhead associated with the tracking terms in the cost function. Finally, the interaction between processor speed and the number of cores still needs to be investigated. There's a financial trade-off between a faster processor and more cores. So for a fixed cost, you could have a faster processor or more cores, but not both. In future work, we plan to assess the generality of parallel computing in OPENSIM MOCO by simulating different movements, as well as using a 3D model to increase the complexity. Thank you for listening.
Thank you very much, and thank you to our first block of speakers. We will now move into the question portion of the session. Reminder to either raise your hand or put your question in the chat indicating the speaker that it's directed at. And at this point, I will pass the mic to Drs. Johnson and Gaffney to ask the questions from the group.
Great, so great block of talks there. So we're going to try to get hopefully 1 or 2 questions per speaker. So let's just start off with first question from Ross Miller to Julia. Many 3-dimensional models do not have a subtalar joint. Do you think it's better, i.e. lesser of 2 evils, to include a subtalar joint that isn't aligned right or to exclude it entirely?
That's a good question. And like I said, a lot of times the kind of rule of thumb is to lock the subtalar joint, kind of leaving it out of models altogether. But I have looked at what happens if you leave it unlocked versus locked, and it does improve, or at least make the results significantly different, but it depends on what you're looking at. So if you're looking at just walking, the differences aren't going to be that noticeable, so you can just leave it out. But if you're looking at a more dynamic task like running, you should probably include it, even if it's a little misaligned, or using a generic axis if it's looking at a healthy individual.
Okay, thanks, Julia. Our next question is for Molly from Kara Lewis with a great question. She says, great talk and interesting work. Do you think that people with anteversion might change the way they walk, i.e. toe in or toe out? And if so, how might that affect your analysis and findings?
That's a really great question. Thank you. So we actually know that people, if you have toe in gait, you're more likely to have anteversion, but many patients with anteversion actually have normal kinematics. Of course, there are people who also walk with the toe in gait. We maintained the foot kinematics in order to keep the ground reaction forces accurate. If we alter the kinematics down at the foot, we have to alter the ground reaction forces, which is kind of a current modeling limitation we have, but definitely something important to look in the future. We just have not been able to do that yet.
Okay, thanks. So it looks like we have yeah, so we have a question from Jacob Banks for Alex. When you're running the simulations with the 18 cores, were there any issues with overheating or other CPU issues with the 18 core simulations?
We did not. That is a good question and is definitely a major limitation to faster processors. The processor of this computer, I think, was 2.6 gigahertz.
Okay, just for even distribution, I'll ask a question to Kelsey. So you looked at changes in peak contact pressure, but you talked a bit about kind of the distribution or hinted at contact area. So I'm curious to see if you were looking at that, or what are some of your preliminary findings in terms of how the load is distributed across the cartilage surface?
Yeah, so that's why we broke it into 6 different regions, was to kind of find a quick way to assess these, because there's a possibility we'll end up looking at it as a full distribution. But right now we just wanted to see in these areas that are loaded if we're seeing a shift in where the peaks are happening, if they're occurring in different regions at different time points. But we definitely plan on doing it, looking at area as well, once we get a few more subjects.
All right, looks like we can start circling back to second questions for speakers. So here's one from Reed Gerchik. Did you find that virtual markers tracked experimental, this is, sorry, to Julia. Did you find that the virtual markers tracked experimental markers better for one subtalar axis definition over another in the IK analysis? If this wasn't examined, what would you expect to find?
So marker tracking and subtalar joint is very difficult in general, just because of skin artifact and the talus moving about randomly. And I think that's one reason why a lot of models just leave it out or lock it, so you don't really know what happens. So it'd be tough to say how it matches, but it is important to look at different orientations and how they're calculated. So Inman looked at non-weight bearing cadavers, and so his inclination deviation angles might be different than when you look at the CT weight bearing axes calculations. So that's important to consider as well.
Okay, good discussion. I think to stay on time, we'll switch to our next block of speakers. And so with that, I will introduce our co-moderator here, Russell Johnson, and he's going to discuss step time asymmetry does not impact metabolic cost in models with unilateral weakness.
Now I lost my PowerPoint. Oh, there we go. All right, thank you for the introduction. So our lab is interested in how people post-stroke walk. After someone has a stroke, there are several neuromuscular impairments that occur, including hemiparesis, spasticity, and abnormal muscle coordination, and as well as other things. In addition to that, we also know that people post-stroke walk with step time or step length asymmetries, and they have a greater metabolic cost during gait. And here's an example of the metabolic cost with cost of transport on the y-axis. People post-stroke, their cost is on the left, and then age-matched controls being on the right. We also know that a common rehab objective for people post-stroke is to reduce their spatial temporal asymmetries, to walk with symmetrical step times or step lengths. Now, one of the things our lab is interested in is determining causal associations between specific impairments, spatial temporal asymmetries, and metabolic cost. But with people post-stroke, these impairments occur simultaneously, so it's difficult to tease apart how specific impairments would affect these things. However, with musculoskeletal modeling and predictive simulation, we can develop hypotheses for how gait performance and metabolic costs could change with specific impairments. Now, for this, we're going to focus on hemiparesis, or muscle strength reduced on one side of the body more than the other. So the aim for this project is to quantify the spatial temporal asymmetries and changes in metabolic costs that emerge when muscle strength is unilaterally reduced on a model with predictive optimizations. Once we do that, we're then going to ask, does enforcing spatial and temporal asymmetry result in changes to the metabolic cost? So to do this, we used a two-dimensional sagittal plane model that had 24 muscle tendon units and 11 mechanical degrees of freedom pictured here on the right. So there's 12 muscles per limb, and the pelvis and trunk were rigidly connected. This was our baseline model, and then we created 3 other models from there by reducing the strength on the left limb by either 20%, 40%, or 60%, uniformly across all 12 muscles on that side. And this created 4 total models. We then generated predictive simulations via OPENSIM MOCO, which you just heard about, across 5 different speeds from 0.25 meters per second to 1.25 meters per second. And for each of these optimizations, we minimized the muscle excitations cubed across all of the muscles. From then, we selected certain speeds to then reduce asymmetry in either step time or step length. Now, for the 1.25 meter per second condition, we added a cost to the objective function to reduce step time asymmetry, therefore targeting step time symmetry for each of the 4 models. And then at 0.75 meters per second, we added a cost that targeted step length symmetry. And then for all of these conditions, we estimated the metabolic cost of transport using the Umberger 2010 probe that's built into OPENSIM. I'm just going to present the results for the 1.25 and 0.75 conditions here. So first, starting off with the nominal cases for each of the speeds. So to orient you to this figure on the right, so the step time is on the top, or step time asymmetry is on the top, step length asymmetry is in the middle, and then metabolic cost is on the bottom. The x-axis is the type of model, so 0 representing the symmetrical base model, and then 20, 40, or 60% reductions in muscle strength. And then the y-axis for the top 2 are asymmetry index, with 0 representing symmetry, and then the bottom being cost of transport. So you can see in the 1.25 case, step time asymmetry increases with weakness, and in the 0.75 case, step length increases with weakness. So we first targeted the step time asymmetry. So we created simulations with symmetrical step times, and we noticed that the metabolic cost of transport did not change across any of the conditions. And then in step length, when we simulated a symmetrical step length, the metabolic cost also did not increase. And you'll also notice that the opposite domain of asymmetry, either length for this case or time for this case, did change. So there is changes in asymmetry, but or from the nominal case. So overall, we noticed that the magnitude and direction of gait asymmetries based on our effort optimal predictions varied depending on both the weakness of the model as well as the speed at which it walked. However, reducing these asymmetries for models with hemiparesis did not have any effect on the magnitude of the predicted metabolic cost. Again, it did change the other domain of asymmetry. So therefore, our results suggest that multiple gait strategies could result in similar metabolic cost for individuals with hemiparesis. And you'll see a quick video of that on the right, thanking the funding sources, and I'm happy to answer questions, spatial chat, or with my contact info here.
All right, thank you, Russell. Next up, we have Ricky Pimentel, and he's going to talk about, does push-off intensity mediate the effects of tendon stiffness on walking metabolism?
All right, thank you. And I'm going to try and answer this question. Does push-off intensity mediate the effects of tendon stiffness on walking metabolism? So older adults walk with greater metabolic costs compared to young adults for a variety of reasons, such as muscle biochemistry, body composition, and even preferences in neural control and movement patterns. While all of these certainly contribute to the increased costs with aging, we think reduced tendon stiffness plays a major role. Onambele and friends showed that older adults have lower tendon stiffness compared to young adults. And more recently, Orselli found that less stiff plantar flexor tendons also increase the metabolic cost of walking. We also observed that older adults walk with reduced push-off intensity compared to young adults, and this push-off intensity is primarily controlled by the plantar flexor muscle tendon units. So we wonder, do older adults reduce their push-off intensity to mitigate the metabolic consequences of lower tendon stiffness? So in this study, I'll first benchmark how different tendon stiffnesses affect simulated metabolic cost, and then answer this question, does push-off intensity mediate the effects of tendon stiffness on walking metabolism? Our lab uses targeted biofeedback to cue young adult walking. We found that young adults can mimic many of the aspects of older adult walking, such as push-off force, joint dynamics, and metabolic cost. This allows us to compare across biofeedback conditions as a model for aging. In our experimental design, we measured peak propulsive force in real time and displayed it on a screen in front of the participant. We recorded walking motions and forces to create simulations of each person's walking in OPENSIM. But before we get there, we changed tendon stiffness or changed tendon strain at maximum force to 2, 4, 6, and 8% for all muscle tendon units in the model, with 3.3 being the model default. Then we move forward with performing musculoskeletal modeling at each push-off intensity and tendon stiffness level by simulating the metabolic cost of walking using the average of 2 different metabolic cost models. Onto our results. First, we'll benchmark how different tendon stiffnesses affect the metabolic cost by looking at the normal push-off intensity condition. And we found a 3 to 5% increase in the metabolic cost of walking with reducing tendon stiffness. We can break that down as a function of the gait cycle. The gray shaded regions here indicate a significant repeated measures ANOVA within subject's effect for tendon stiffness. And while there are a few areas where more stiff tendons increase metabolic cost, we highlight areas where less stiff tendons have higher metabolic cost because that follows the overall trend. These increases in metabolic cost occurred in early stance phase, during push-off propulsion, and late swing. So now I'll move on to our primary question, and I'll show these results in a heat map with the metabolic cost from the norm condition and the default tendon stiffness in white, with higher and lower metabolic costs in red and blue, respectively. We can see that 3 to 5% cost increase again in the norm condition across all tendon stiffnesses. And keeping tendon stiffness constant at our default levels, we can see metabolic cost change in response to varying push-off intensity. Zooming out to all conditions and all tendon stiffnesses, we see that metabolic costs increase with less tendon stiffness. Metabolic costs also generally increase as we deviate from the norm push-off intensity. And we also found a local minimum with stiff tendons and small reductions in push-off intensity. We found significant repeated measures ANOVA main effects across push-off intensities and tendon stiffness levels, with effect sizes explaining about 1/3 of the variance accounted for in metabolic cost. But we did not find any significant interaction effect between push-off intensity and tendon stiffness. So in conclusion, reducing tendon stiffness increases metabolic cost, changing push-off intensity increases metabolic cost, and in terms of metabolic cost, push-off intensity does not mediate the effects of tendon stiffness. It appears that the push-off intensity and tendon stiffness contribute independently to the metabolic cost of walking. Thus, they should be addressed individually for rehabilitation interventions. So thanks to my lab members, our research participants, and the NIH for funding this, and OPENSIM for letting us run all these simulations. Thank you.
Thanks, Ricky. Our next talk is by Janelle Kaneda, entitled Static Optimization to Detect Changes in Medial Knee Contact Force, a Validation Study.
Thank you so much. Can everyone see my slides? Great, okay. Hello, everyone. My name is Janelle, and I'm a master's student in bioengineering at Stanford University. Today, I'll be presenting a study that I've worked on with co-authors from the Neuromuscular Biomechanics Lab that validates static optimization's detection of changes in medial knee contact force. Although increases in medial contact force are associated with medial knee osteoarthritis progression due to the tissue-level relationship between contact force and cartilage breakdown, non-invasive interventions like gait modifications often target knee adduction moment, which is easier to measure and has more clinical evidence, but is not always associated with medial contact force trends. So, gait modifications targeting medial contact force peaks directly could be more effective. In order to evaluate this, we need to use musculoskeletal simulation since medial contact force can't be directly measured in native osteoarthritic knees. Since simulation is also a proxy, it's important to validate methods like static optimization against measurements from instrumented knee replacements to evaluate accuracy. The purpose of our study is to evaluate how accurately static optimization estimates changes in medial knee contact force peaks. Our goal was to evaluate how well a generic method performs that doesn't require excessive equipment. We simulated medial contact force for 3 subjects with instrumented knee replacements in the 3rd, 4th, and 6th knee load grand challenge competitions. Across the subjects, we analyzed baseline walking and 12 unique gait modifications known to induce changes in knee loading peaks. We use standing static poses to scale subject-specific full-body musculoskeletal models with a multi-compartment knee to resolve medial and lateral forces. We used a custom static optimization algorithm in MATLAB with passive muscle forces, tendon compliance, and minimize the sum of squared muscle activations, followed by OPENSIM's joint reaction analysis tool to estimate medial contact force. We defined the first and second medial contact force peaks as the maximum value between 15 and 35% and 65 and 85% of stance, respectively. The medial contact force peaks from instrumented knee replacements were calculated using previously reported regression equations. Overall, our simulations had less error at peak 1 than peak 2. Shown here is medial contact force versus percent stance phase for mean measured force in black and mean simulated force in red. The mean absolute error, or MAE, across all 115 trials at peak 1 was 0.16 body weights, where we tended to underpredict compared to the measured force. The MAE at peak 2 was 0.31 body weights, where we tended to overpredict. Since we're mainly interested in gait modifications that change medial contact force peaks, to evaluate how confident we can be in these changes, we calculated accuracy as the proportion of peaks that had correct direction changes from baseline for simulated force thresholds. Percent accuracy in direction changes on the y-axis, and the simulated force thresholds for changes at that amount and greater from baseline are on the x-axis. If we focus on the thresholds around 0 at peak 1, both increases and decreases from baseline above 0.1 body weights had direction change estimates with accuracy at or above 70%. When we move that threshold to 0.2 body weights, accuracy increases in both directions. Increases above 0.4 body weights had perfect directional accuracy. At peak 2, we're confident in decreases above 0.1 and 0.2 body weights, which had accuracies around 80%. Decreases greater than 0.8 body weights had perfect directional accuracy. However, we're not as confident in increases, where accuracy was less than 50% at thresholds of 0.1 and 0.2 body weights. The overall lower accuracy at peak 2 may be due to greater possible muscle coordination patterns during late stance, as reported by Demers and colleagues. In conclusion, we show that a generic muscle redundancy solver is sufficient to detect most changes in medial contact force peaks greater than 0.1 body weights. Our study suggests that if your simulation results show peak changes of this magnitude, then you can have confidence that these are accurate. Estimates for increases at peak 2 could be improved with more complex methods that incorporate electromyography. having sufficient accuracy for detecting reductions at both peaks suggests that static optimization can be used for evaluating gait modifications without the need for expensive equipment and the difficulty of EMG for certain patient populations, like those with osteoarthritis. I'd like to thank my co-authors, funding support, and affiliation shown here. I look forward to discussing further and answering any questions. Thank you.
Thanks, Janelle. Our final speaker in this block is Dennis Anderson, and he'll talk about dynamic lifting tasks yield larger thoracic and lumbar spinal loads compared with quasi-static lifting.
Thank you. Can everyone hear me? All right, thank you. My name is Dennis Anderson. I'm an assistant professor of orthopedic surgery at Beth Israel Deaconess Medical Center and Harvard Medical School. I want to begin by acknowledging all of my co-authors, in particular, Caitlin Burkhart, who did most of the work here and has moved on from our lab to a job at Apple. Also, this work was funded by the NIH, and we have no conflict of interest to report. So much of the work in our lab centers on understanding motion and loading of the thoracolumbar spine. And so
Dennis, we can't see your slides. Could you try sharing?
Back up. Can you see my slides?
Good. Looks good. Go for it. Thank you.
Sorry. All right, so I will skip the beginning slide and just go on from here. So much of the work in my lab centers on understanding motion and loading of the thoracolumbar spine. And so as a central part of this, we have been, over the past several years, developing and applying musculoskeletal models to evaluate spinal loading, as well as a repository of 250 subject-specific models from the population-based Framingham heart study. And so we can use these this group of models to kind of explore and understand variations in the population. And so we recently used this group of models to examine which of more than 100 static loading scenarios produced the largest loads in various regions of the spine. However, there's some definite limitations to what we did there, in particular that it involved no subject-specific kinematics, and also that we know that static loads are likely to underestimate loading in a dynamic lifting task. Thus, the aim of the current study was to examine spine loading in a static versus dynamic lifting using measured kinematics and subject-specific models. So we had collected data in 6 healthy participants lifting a box of 10% body weight, and we created musculoskeletal models of each subject, scaling to anthropometry, as well as spine curvature and trunk muscle measurements made in CT scans of the subjects. We performed inverse kinematics and static optimization analyses in OPENSIM to derive the dynamic spine loading. And then from the dynamic spine loading, we found the time point of peak loading, and we reanalyzed this time point as a static lifting pose to provide a comparable static load for comparison. So the point of peak loading occurred, as you might guess, while the subjects were flexed forward but lifting the box. And so you see the spine and pelvis and hip angles here and the angular velocities. There was quite a bit of variation in angle and angular velocity between the subjects, as we were not trying to control like their lifting pose or velocity. For the compressive loading of the spine, we saw significant increases with dynamic loading versus static loading by an average of 21 to 36% across various levels of the spine. Most of the levels of the spine also showed an increase in shear loading, with the exception of T12 and L2, where there was no significant difference, and L3 and L4, where there was a difference, but the shear there is posteriorly directed rather than anteriorly directed. Finally, we found that the dynamic loading was very highly correlated with the static loading, with R² of 0.99 for both the shear and the compressive loading outcomes. So not surprisingly, the results demonstrate a substantial effect of dynamics on the spine loading. And this increase of 20+%, would certainly be meaningful for some studies in the context of injury risk or other clinical biomechanics outcomes. What was a little surprising was the consistency of this effect across the subjects and vertebral levels. And so you can see here's the correlation that we saw for the compressive loading, and it's just a very straight line. And this is despite the variability in dynamics between the subjects. And so this kind of suggests that you could predict dynamic loading accurately from a static postural load. And so as an example of this, we used this result here just to predict an estimated dynamic load from the Framingham heart study population that I mentioned earlier, where we had calculated static loads in 250 people for a similar lifting task. And so now we can sort of adjust that into a dynamic loading, which might be more relevant. And so, we hope that this type of approach could improve the feasibility of evaluating dynamic loading for large studies, such as this Framingham population, or for clinical applications. So there are some limitations, and so our next steps include incorporating some additional subjects that we have collected in our lab, and definitely evaluating other dynamic tasks. And finally, to determine the ability of more generic static postures to predict these subject-specific dynamic loads. So thank you for listening, and I will be happy to chat with you in spatial chat later, or feel free to reach out by email.
All right, thank you to all of our speakers. I'd now like to turn it over to Drs. Silverman and Johnson to lead the discussion.
Great, thank you to all the speakers. First question I will ask to Russell, which comes from Jacob Banks. Says, is the Umberger and/or a 2D model that you've used in this study sensitive enough to look at the changes that you're interested in?
Yeah, it's a great question. So on the Umberger metabolic model, so I've also tested the metabolic cost using the Bargava model. I just didn't show that today. So the Bargava model is another type of metabolic model that we can use to estimate metabolic cost. And the results for that, the metabolic cost, the absolute value of the metabolic cost increased a little bit with the Bargava model compared to the Umberger model, but did not change any of the results. They were still identical, essentially identical between conditions. Now for the 2D model, I think that's a potentially an interesting complexity to the study. So we decided to keep it to 2D because we were mostly interested in the sagittal plane spatial temporal asymmetries, so the step time and step length. And of course, with post-stroke gait, you often see compensations outside of the sagittal plane, which might interact with spatial temporal asymmetry. We haven't quite tested out like what a 3D model would look like for these conditions, but I think it would be a reasonable next step to look at. And I will just go ahead and ask the next question. So the next question comes from Allison Sander to Ricky. She says, great job on your presentation. It looks like the screen in front of the participant guides their gaze upward and forward. In older adults, gaze may be directed downwards and with increased trunk lean. How do you think changing the gaze angle could impact gait or balance in your participants?
Thanks for your question, Dr. Sander. Our illustration may have induced some parallax in our actual system. So that screen is actually fixed in the ground. It's on a rolly cart, and it's generally between, like, the base of the screen is about chest high, stomach high, depending on the height of the participant. So we may want to change the height of the screen, perhaps in future experiments, to maybe account for this trunk lean. That could be an interesting study to see how that may affect metabolic cost. But yeah, that definitely could be a factor. And thanks for pointing that out.
Our next question comes from Hugo Gambini to Dr. Anderson. The values on slide 5 are smaller than those observed experimentally on human cadaveric vertebra, or are those predicted using QCT or FEA? Can you elaborate on what the compressive load means and how it is computed to yield those outcomes? Are muscles involved in the calculations, and which ones?
Yeah, I find the question a little bit confusing. Are you referring to, like, compressive strength from testing cadaveric vertebrae? If that's the case, that's not what this model is doing. This model is calculating compressive loading during a lifting task. And it does involve muscles. The OPENSIM model has more than 500 muscle fascicles involved, including all the major spinal muscles.
All right, so in the interest of distribution, I can ask a question to Janelle. So Janelle, I was interested in how the peak 1 and peak 2 were different in how accurately you were able to predict it. And you mentioned something about peak 2 being maybe related to muscle activations or maybe using EMG to further refine it. Have you, I was curious about, like, what you thought, if you could dig into that a little bit more, or if you had dug into that a little bit more, elaborate.
Yes, definitely. Thank you for the question. So we haven't specifically looked into analyses incorporating EMG explicitly yet. However, to speak more about the results we were seeing at peak 2, again, I think it might be a combination of two things. So first, as reported by Demers and colleagues and others as well, we usually tend to see a greater number of possible muscle coordination patterns at peak 2. So this leads to, a greater number of different muscle activations that static optimization can output, and thus more chances for it to be a little bit more inaccurate. Secondly, in general, for the gait modifications we were evaluating, those tended to mostly have decreases at peak 2. So we didn't have a quite as large of a sample size for increases at peak 2. So that could also contribute to the lower accuracy that we detected. In addition, adding 2 or 3 more points could possibly shift that up a little bit. So that could be a great way to incorporate for future work.
I think we have time for one more question. We've got one for Ricky from James Finley. Your simulations seem to illustrate that there is an optimal level of push-off that minimizes metabolic costs for a given level of tendon stiffness. If this is true, might older adults select a level of push-off that is energy optimal based on their tendon stiffness?
Yeah, thanks for your question, Dr. Finley. And this is definitely a driving cause of our simulation study. So we know that not everybody has the same tendon stiffness levels. And so that's why we are changing all of these tendon stiffness levels and estimating metabolic cost across this push-off intensity landscape. And while we have some pretty decent results for this round of simulations, this was, at least the data was collected in all young adults. So we would expect more stiffer tendons. So we might want to replicate this study in older adults to see if this holds up and if this holds true.
Well, great. I think in the interest of time, we'll move on to our third of 3 blocks. And so with that, I will introduce our 9th speaker of the session. So our 9th speaker is Maria Prado, and she's going to talk about phantomless calibration methods for vertebral fracture properties estimation using QCT-based FEA.
Yeah. Can you hear me? Yeah. Okay, thank you. Yes, my name is Maria Prado. I'm part of the University of Texas at San Antonio, and today I'm presenting the study of functionless calibration methods for vertebral fracture properties estimation using QCT-based FEA. Okay. Osteoporosis result in bone loss and an increase in the risk of fracture. Osteoporotic fracture-related costs in the US are estimated to increase to 25.3 billion by 2025. In this context, vertebrae are the second most common affected bones, with a fracture incidence exceeding 1.4 million annual cases in the US. Bone mineral density is the gold standard method for fracture risk diagnosis, and DEXA is the most common method for estimation of BND. However, DEXA presents several limitations, including that overestimate the BND in the lumbar spine, and that is not able to assess the three-dimensional details of the vertebrae. So to overcome these limitations, we propose the use of quantitative computer tomography-based final elements analysis. QCT-FEA is a promising tool for fracture risk predictions that is becoming about attractive as a clinical management approach. QCT-FEA integrates bone geometry, distribution, and properties. To obtain QCT-FEA subject-specific estimates of fracture properties, the Hounsfield units values from the CT images are converted to BND using a calibration phantom. However, this calibration phantom also presents some limitations, including that it's really expensive and that is not always available in clinical. So to solve these different problems, we propose the use of a patient-specific phantomless calibration technique. So the purpose of this study was to develop a robust and novel phantomless calibration methods using subject-specific tissues, which could be applied prospectively and retrospectively to databases of CT scans to obtain fracture properties estimation using QCT-FEA. As part of the methods, we used a total of 111 subject CT scans. 80 of the total scans were used for the development of phantomless calibration equations, while the remaining 31 scans were used for cross-validation. Then a series of phantomless calibration equations were developed based on the Hounsfield units measured from different tissues and regions, including the air, the fat, the psoas muscle, and the perimeter of the subject. Equations are a combination of the regional interest, and to develop the phantomless calibration equations, we use a multiple linear regression model where the coefficients C1 to C6 were obtained using this regression analysis. Then we implement a QCT-FEA model that has been previously validated using a material equation from literature and a fraction criterion that estimates the fracture load as a function of vertebral stiffness and height of the vertebrae. As part of the analysis, we obtain the BMD correlation using phantom and phantomless methods, and the predicted strength using various methods were correlated to DEXA aerial BMD. The results obtained give us the idea that the proposed phantomless methods can successfully be used in QCT-FEA to estimate vertebral fracture loads that are highly accurate and correlate with fracture loads obtained using the traditional phantom calibration methods. The equations using the perimeter of the patient highly correlates with outcomes using the calibration phantom with values of 0.99. On the other hand, in order to validate and evaluate the precision of the predicted fracture loss outcomes, the aerial BMD values from DEXA were correlated to QCT-FEA predictions, showing moderate correlation with value of 0.68. Additionally, we correlate with a correlation of outcomes between QCT-FEA fracture loss estimates from the calibration phantom versus the phantomless calibration were high, with values between 0.94 and 0.99. As a conclusion, we can say that the phantomless approach presented in this study can be used for osteoporosis diagnosis and QCT-FEA fracture risk assessment using images that has been previously obtained for other purposes or prospectively without the use of a calibration phantom, minimizing the logistic controls and other limitations that are associated with external reference phantoms. Thank you, everyone.
Great, thanks for that great talk. We'll move on to our next speaker, which is Michael Polanco. He will talk about the effect of costovertebral joints on the motion of a thoracic spine functional unit.
Hey, can everybody see my screen? Yep, okay. So good afternoon, ladies and gentlemen. I would like to begin my presentation by thanking and acknowledging my co-authors as well as my sources of funding listed on the slide for the following presentation. Costovertebral joints are serving as the primary connection between the rib cage and the thoracic spinal column. They are integral in helping humans perform everyday activities such as breathing facilitation, and they also help to stabilize the spinal column. Their proper representation in a computer model can help enhance surgical planning for treatment of musculoskeletal disorders. However, the level of representation of the costovertebral joint has been varied in previously conducted studies. So for example, some experiments which are considered a standard for computer model validation may or may not have the costovertebral joint represented. Such an example is shown here for a experimental thoracic functional unit with the costovertebral joint absent. In some computer model representations of the costovertebral joint, they either have the joint explicitly modeled using ligament connections, or they can have the joint simplified to a spherical joint connection between the rib and the adjacent spinal column. So the purpose of this talk is to assess the kinematic sensitivity of a thoracic functional unit with and without the costovertebral joint represented, while demonstrating reinforced kinematic behavior by explicitly modeling the costovertebral joint. So to do this, I have a T78 functional unit that was created and analyzed using LS-DYNA. And so this functional unit was quasi-statically rotated in flexion, extension, left and right lateral bending, and left and right axial rotation using two different configurations. So the configuration on the left is showing the functional unit without the costovertebral joint, and to the right with the costovertebral joint. The joint complex shows a portion of rib with ligament-based connections to the functional unit. The portions of the functional unit, the ligaments that make up the complex of the costovertebral joint are labeled here. And finally, the graph on the right is showing the input properties to the ligaments making up the costovertebral joint complex taken from the literature. So what I'm showing here is just an example of the functional unit rotating in this case, right lateral bending. And so if you compare the animations in the top row to the animations in the bottom row, you're seeing the effect of the reinforced kinematic behavior when you have the costovertebral joint present versus absent, as denoted by the levels of shaded red at maximum rotation on the bottom. So if we dig deeper into the results that were acquired, we see that, by the way, right lateral bending was shown because the results were showing the greatest reinforcement by approximately 14% when we compare that with the functional unit that didn't have the costovertebral joint present. And you could generally see this trend through the 6 different rotations that were applied on the functional unit, as shown in the graph. If we just take a look at the configurations without and with in blue and red respectively. And we also have the added benefit of comparing the in vitro experimental results, which had the like different functional units, including the costovertebral joint in different modes of rotation. They match well in flexion and axial rotation. However, we do have some degrees of compliance and extension and unilateral bending, which may need further investigation of the intervertebral joint ligament properties for future iterations of this study. So to conclude, the representation of the costovertebral joint as presented was able to demonstrate proper stiffening behavior. However, what you notice is the level of stiffening was not as pronounced, and that's because you didn't have the ribs completely closed. So regardless, the plan is to carry over this exact setup to a full model of the spine with the rib cage included, to move in future work involving simulation of clinical procedures, namely scoliosis surgical planning. And we do expect more reinforced stiffening as a result of the rib cage being included. That concludes my presentation. Thank you for listening.
All right, great, great talk. We're gonna move on to our next speaker. And our third speaker in this block is Joshua Pataki, who will speak about joint loading is affected by rotator cuff tear severity and task performance.
Oh yeah, thank you for the introduction. So rotator cuff tears are common in older adults, with tear severity ranging from partial thickness to massive 3 tendon tears. Previous modeling studies by our group have shown that with increased tear severity, glenohumeral joint contact force, the force of the humerus on the glenoid fossa of the scapula, is relatively consistent for static postures. We also observed that those forces change with increased humeral elevation, and it is possible that the imbalance of muscle forces from the cuff tear could lead to secondary effects. However, it is unclear how joint contact forces change with dynamic tasks, what outcomes could be expected based on tear severity. Therefore, our objective in this study was to determine how glenohumeral joint contact force changes with increased rotator cuff tear severity and dynamic task performance. A computational musculoskeletal model of the upper limb was developed in OPENSIM to represent mean muscle force generating characteristics of healthy older adult males. The model was then modified to represent 8 different rotator cuff tear severities by systematically reducing the peak isometric force of the supraspinatus, infraspinatus, and subscapularis muscle pads. A baseline model was created to represent the healthy rotator cuff, in which each of the 4 cuff muscles were at 100% of their peak isometric force. A partial thickness tear of the supraspinatus tendon was modeled next by reducing its muscle force to 50%. This was continued through for massive tears, including all 3 muscles. Kinematics for 5 tasks performed in many daily functional tasks were measured in a prior study from a cohort of 18 older adults, both with and without a rotator cuff tear. The tasks performed include a forward reach, functional pull, axilla wash, upward reach to shoulder height or 90 degrees, and upward reach to 15 degrees above shoulder height or 105 degrees. With the models and the task kinematics, a series of computational simulations were performed using OPENSIM's computed muscle control and joint force analysis tools. The peak resultant joint contact force from each simulation was identified and averaged for each tear severity, then compared to the no rotator cuff tear model. First, we'll take a look at the magnitude of the peak joint contact force for forward reach. Compared to the no rotator cuff tear model, we do not see a large difference for only supraspinatus tear models. However, when the tear includes the infraspinatus tendon, we do see a significant decrease. This significance is maintained when the tear severity increases to include the subscapularis tendon. The decrease in force plateaus once the most severe tear severities are reached. Next, when we begin to bring in the resultant peak joint contact force for the rest of the tasks, we see very similar results. For each task, there are small decreases in joint contact force for supraspinatus tear models. When the infraspinatus and then the subscapularis tendon is involved, there is significant reductions in joint contact force magnitude for most tasks. One exception to that we see here is the upward reach to 105-degree task, which shows a decrease, though not a significant one, potentially from increased humeral elevation. Now, look at the projection of the peak joint contact force from the humeral head onto the glenoid fossa. The ellipse represents the glenoid rim and the white dot the geometric center. The colored dot is the orientation of the peak joint contact force for the no cuff tear model. As seen, the projected force is slightly in the posterior superior quadrant, although well within the glenoid rim. Progressing to the greatest tear severity, noted by the colored square, the force moves more posterior and superior. While superior translation could indicate superior humeral head translation, even at the greatest tear severity, the force remains within the glenoid fossa. We look at the projected orientation for all tasks. Again, increased tear severity results in a posterior superior shift compared to the no cuff tear model, the remaining within the glenoid rim. As the tasks involve more humeral elevation, the orientation from both the modeled tear severities is directed more inferiorly, though with increasing tear severity, we still see the posterior superior shift. In this work, there were differences observed between the tasks performed, most notably the upward reach to 105-degree task. While forward reach, functional pull, axilla wash, and upward reach to 90 degrees have similar patterns of change showing contact force magnitude with increased tear severity, upward reach to 105 degrees showed varied results. This suggests postural diversity, notably greater upper limb workspace use, yields different loading conditions. For all tasks, when tear severity increases, the magnitude of the peak joint contact force decreases. Additionally, for all tasks, a significant posterior superior shift in joint contact force orientation was seen for increasing tear severity. These descriptions of changes to joint contact force loading may also be helpful in identifying possible thresholds beyond which shoulder function begins to decline or injury risk markedly increases, which is the focus of our current work. I'd like to thank the funding sources and my lab mates for assistance in this research. And I'd like to thank you for your time and look forward to answering any questions.
All right, we'll go on to our final speaker of the session. So our last speaker today is Konstantin Nikolazaks. He will speak about shoulder muscles with large lines of action contribute to glenohumeral stiffness. I think the host should be able to unmute Konstantin.
Okay, there's a start. Let me see if I can. Do you think you could turn on screen sharing? Oh, beautiful.
Yeah, you should be co-host now.
All right, can you see it?
Yes.
Beautiful. All right. Good afternoon. I'm Konstantin. I'm from Northwestern University. I'm going to talk about some of our newest results about how shoulder muscles with large lines of action contribute to glenohumeral stiffness. And I'll start with my main acknowledgement up front. This was funded in part by the ASB Graduate Student Grant and Aid. So I'll begin by briefly introducing the concept of glenohumeral stiffness, which is a resistance to humeral head translation. Previously, we've shown that the glenohumeral stiffness, like here on the y-axis, increases with increased muscle activation, or specifically torque magnitude, which you see on the x-axis. And the result of these active increases in glenohumeral stiffness are increased resistance to glenohumeral translations, which can help prevent unwanted humeral head translations and eventually dislocations. Next, we wanted to ask how individual muscles contribute to these increases in glenohumeral stiffness. Why rehabilitation for shoulder instability targets the strengthening of different and specific muscle groups. Two important groups that are considered in rehabilitation, one are the rotator cuff muscles, which are prioritized because they're recognized as the primary active stabilizers, but also primary shoulder movers, which must be strengthened to augment torque generating tasks, but may also actively destabilize the joint. Our long-term goal is to ensure we're targeting the most efficient stabilizing muscles during rehabilitation for shoulder instability. And to begin to accomplish that goal, we first asked how do changes in muscle activity correspond to changes in glenohumeral stiffness? And we compared this relationship between rotator cuff muscles and primary shoulder movers. 15 subjects participated in our study, and we translated the humeral head to estimate active glenohumeral stiffness, or the amount that muscles actively increase glenohumeral stiffness beyond the passive stiffness of the joint. While translations were applied, participants activated their shoulder muscles in different ways by generating isometric torque in one of 6 directions, like you see here. And we simultaneously recorded background EMG in 3 rotator cuff muscles and 6 primary shoulder movers. And from these EMGs, we created a linear mixed effect model to predict glenohumeral stiffness from the EMGs of muscle in each group. And to visualize the result, I'll show some graphs here with active stiffness predicted just from EMG on the y-axis and experimentally estimated active stiffness on the x-axis. And the dotted line here reflects a perfect prediction. In the first graph with no muscles and only subject-specific intercepts included, we see a poor correlation between experimental and predicted active stiffness, as we would expect. When adding just the 3 rotator cuff muscles, the predictions mildly improved, accounting for 56% of the variance. but you can still see the dots don't fit very well on that line of perfect prediction. When including only the 6 primary shoulder movers, however, predictions were much improved, accounting for 80% of the variance. And finally, when we add both groups together, all 11 muscles, we only saw a small improvement from the model with only the primary shoulder movers. Our next question was why? Why did muscle activity in primary shoulder movers correlate better with active glenohumeral stiffness? Historically, the primary mechanism that has been studied in cadavers of actively increasing glenohumeral stiffness is called concavity compression. In this mechanism, muscles compress the humeral head, like the golf ball you see here, into the concave glenoid, like the T. The more compressive force, the more likely the humeral head will stay centered when exposed to translational forces. The muscles that stabilize the best through this mechanism are the rotator cuff muscles because they produce predominantly compressive forces. However, as I talk about primary shoulder movers, we've hypothesized another potential stabilizing mechanism that may be preferentially used by the primary shoulder movers. Muscles can also act as springs that can increase their intrinsic stiffness when active. Applying this established concept to the shoulder, when these muscles are stretched by humeral head translations, they can directly resist the translations and thereby increase glenohumeral stiffness. In this case, muscles with larger lines of action that are more aligned to the directions of translation, like the primary shoulder movers, may be situated better to directly resist humeral head translation. So we developed a biomechanical model to predict how shoulder muscles increase glenohumeral stiffness through concavity compression and intrinsic muscle stiffness. I'm not going to go into the details of the model today, but our model predicted that 35% of the total active stiffness from primary shoulder movers comes from intrinsic muscle stiffness, whereas only 18% of the stiffness provided by rotator cuff muscles comes from the intrinsic muscle stiffness. So both groups stabilize predominantly still through concavity compression, but intrinsic muscle stiffness acts as this bonus on top of what is provided by concavity compression, especially in these primary shoulder movers. So in conclusion, primary shoulder movers may be important to increasing glenohumeral stiffness and helping protect against shoulder instability. Concavity compression is the predominant glenohumeral stabilizing mechanism, but primary shoulder movers potentially leverage their intrinsic muscle stiffness to produce larger active increases in glenohumeral stiffness. And finally, the strengthening of primary shoulder movers should be continually emphasized during rehabilitation for shoulder instability, given their potential stabilizing capacity. Thank you.
Yes, great talk again. I'll turn it back over to Dr. Silverman and Gaffney to lead the Q&A session for this third block.
Great, thank you to all the speakers, and we already have some questions coming in the chat. So our first question for Maria is asking about your subject's age group and range. This is from Dennis Anderson. Bone and muscle density decline with aging, and that could affect the generalizability of this approach. And others have used aortic blood as a phantomless calibration point, and we're wondering if you considered this.
Yeah, thank you for the question. Well, we use a group of people older. I can give you the specific ages of our group. So all of them are older than 50 years. So that were our subjects of interest. And he's also asking about the and yes, because we are mainly interested in about the osteoporosis and how the osteoporosis affect the vertebra or the risk of fractures. So that's why we were focused on that, and that was our group of interest. And we didn't consider the aortic blood for the phantomless calibration. That's something that maybe we can look forward, but for now we're interested in these regions that has been previously evaluated as an interest.
Okay, thanks, Maria. Our next question is from Dennis Anderson for Michael about how the facet joints were characterized within your spine model.
Yes, thank you for the question. So the facet joints were just simply characterized using a penalty-based algorithm in the finite element software that was offered. And in addition, the capsular ligament complex that surrounds the inferior and superior facet complexes were characterized using tension-only discrete elements bilaterally. And the properties were taken from literature also.
Thank you. I'll go ahead and ask a question for Joshua, which is, as I understand it, you modeled the severity of the tear by adjusting the strength of the muscles in your model. And I'm wondering what other potential implications there might be after a tear for either passive structures or potentially other properties of muscle that we should be accounting for.
Yes, that's a great question. One thing that we are particularly interested in is possible compensatory responses from other shoulder muscles that could be possibly picking up some of that slack from the reduced strength from the rotator cuff muscles. So part of our current work is actually to look at possibly what other muscles could be could show increased activation or increased force contribution to the shoulder during these tasks.
Thanks, Joshua. I'll go ahead and ask a question for Constantine. I think as modelers, we all can appreciate the difficulty of translation into a clinic or a clinician's hand. So I'd be curious to hear some of your thoughts or some of your workflow within your lab about how you can take this nice type of model and translate that into a clinical setting.
Yeah, so right now from an experimental end, we have some motors, and it was nice because as we had this modeling study going, we were actually able to compare the data and use the muscle activations, run it through our model, see what like the theoretical stiffnesses would look like, and also look at our experimental results from the motor. And we found actually pretty good fit. They fit R squared about 0.78, a lot better than maybe even we expected, just that they were overestimated on the modeling end than on the experimental end. Now the question is, after we start to connect some of the modeling stuff to the end, is how do we go into the clinic and do some of this? And there's a lot of work in the passive end, passive stiffness end, which is pretty straightforward. You can use like simple load cells, you can translate. All of the work there's a lot of limitations to do that, to look at active stiffness. And that's why we're some of the first that put out data on this. But hopefully, as even some simple translational motors that even can do some small steps, the casting the support was actually relatively simple. And one of our other graduate students has built a chair that's going into orthopedic settings and has the load cell set up and kind of has a different study and not necessarily doing the translations, but a very similar setup that she's just sitting right in the orthopedic office. So it is something that definitely, as the motor technology, and we're able to get some of these motors that aren't, ours is 20 years old, is in the like 5,000 volt power source, it feels like. As those start to become more accessible, it's pretty translatable to put in the office or put in on the field somewhere to be able to test some of this active stability, especially among athletes with instability, which is what we're looking at.
Great, thank you. Our next question is for Maria from Karen Troy. Nice to see that the calibration phantoms are not critical as the CT scanners have become more reproducible. The question is, were all of the analyzed scans acquired on the same scanner and with similar settings and reconstruction algorithms? I would be interested to know how much it is still important to continue standardizing these factors.
Thank you, Dr. Troy, for that important question. So for the development of a phantomless calibration equation, we used a single scanner with a clinical CT scanning protocol. So previously, our group has demonstrated that the scanning protocol and the reconstruction affects the BMD estimates. So we need to move forward and maybe to evaluate this calibration of these phantomless equations in different scanning CT scans, but the protocol probably is going to be the same. We can extrapolate this study, of course, acknowledging the difference that we need to take into consideration for a different CT scan. Thank you.
Thank you very much. And we are right at 3:30 Eastern Time. Thank you all so much to all of our speakers. Big virtual round of applause, Zoom round of applause for everyone who spoke today and the great questions from the group. We will be heading over to the MyBridge room and spatial chat to discuss further and get into those questions that we didn't have time for here on Zoom today. Thank you again all for coming, all for speaking, and for the really interactive and enlightening discussion.